G'day, welcome to Emergency Medicine Topics. In one coffee, I'm Giles, I'm an emergency physician, and today's topic is fractured neck of femurs, or fractured NOFs as they're known. But we're also going to look at how to perform an ultrasound guided femoral nerve block. Okay, well, of course, patients with fractured neck of femur are a common presentation to emergency departments. They generally occur in the elderly following a fall, but they may occur in young patients with high velocity injuries such as a motor vehicle accident. Overwhelmingly they present via an ambulance, brought in by the ambulance, but every now and again be careful because they can limp in under their own steam if they have an impacted neck of femur fracture. I'm not going to speak about the possible cause of the fall or even about the general physical examination. Instead, just the affected leg. What do you see clinically? Now, classically, the leg is shortened and externally rotated. However, the degree of rotation and shortening depends on the type of fracture. But before talking about the various types of fractures, we should reminisce on the bony anatomy and the vascular supply. Looking at the bony anatomy, there's the head, neck, lesser and greater trochanters, and the proximal femoral shaft. The blood supply to the neck and head is a tad tenuous. It's derived from the ascending cervical arteries, which come from the medial and lateral circumflex femoral arteries, the medial being the major contributor. The circumflex arteries sit outside the hip capsule, but the cervical branches are intracapsular. There's also a foveal artery, which is a branch of the obturator artery and sits in the ligamentum teres. Now, I might take this opportunity to talk about the AP pelvis and hip x-ray you get, just so that you don't miss subtle fractures. Obvious fractures are, well, pretty obvious. But do a few checks before deciding there is not a fracture. Now, this is Shenton's line. It should have a smooth, not disrupted curve. External rotation makes the lesser tuberosity more prominent. And look at the trabeculae. Are they disrupted? Finally, are there any sclerotic areas caused from impaction? Okay, let's go on to the classification of fractures. Now, this is actually important because there's different surgical treatments depending on different types of fractures. Broadly, the fractures are classified into those which are intra and those who are extracapsular, that is, those are inside or those are outside the femoral neck capsule. Those fractures that are intracapsular then are further divided into the subcapital, transcervical, the mid-neck, and finally basicervical, obviously at the base of the neck. Now, the subcapitals are further divided by the Garden classification, which you might have heard of. It's useful because it predicts the chance of avascular necrosis of the head. The higher the grade, the greater the chance. So here are two examples of Garden grade 1, undisplaced fracture, incomplete. Here's a Garden grade 2, completely across fracture but not displaced. By a Garden grade 3, it's displaced but incompletely. And finally, at Garden grade 4, there's a complete fracture which is completely displaced. As a general statement, grades 1 and 2 are pretty stable and can be treated with internal fixation, and that preserves the head. Grades 3 and 4, by definition, are far more unstable, and these generally require a hemi or a total arthroplasty, especially in the older population. The transcervical, if they're displaced, then they'll often get cannulated screw fixation, and the basicervical, right at the base of the neck, you'll sometimes see them use sliding hip screws for those. When you get to the extracapsular fractures, you're looking at the intratrochanteric and subtrochanteric fractures. Most intertrochanteric fractures are managed with either a compression hip screw or an intramedullary nail, which also allows for impaction at the fracture site. Well, that'll do for making sure you don't sound like a dill when describing the fracture over the phone. I'd like to chat briefly about analgesia. These patients are often frail and elderly. Now, intravenous narcotics are well tolerated by 30-year-old men who come in with renal colic. However, these patients have often low respiratory and cardiovascular reserves. They're lying on their back, so they can be very sensitive to intravenous narcotics. Now, by all means, titrate small doses of intravenous narcotics, but look to perform a femoral nerve block as soon as possible. So what we'll see coming up here is how to perform an ultrasound-guided femoral nerve block.
A high-frequency linear probe is placed transversely in the right groin. The colour Doppler mode is employed to ensure clear identification of a single femoral artery and a femoral vein. If two arterial pulsations are visualized, it means the probe is too distally in the limb, as the profunda femoris has already branched off. It is also important to identify whether the lateral circumflex femoral artery is within the line of needle trajectory. With the colour Doppler now removed, the probe is slid laterally to identify the fascia of the iliacus muscle, or the fascia iliaca, with the fascia lata lying superficial to it. The probe is slid laterally more to identify the lateral extent of the iliac-os muscle as it meets sartorius here. The probe is then slid back towards the femoral vessels. At this point, probe angulation identifying the anisotropic femoral nerve allows clear identification of it here, lying tightly adherent to the surface of the iliacus muscle. In this schematic overlay, you can see the important structures highlighted for clarity. The superficial fascia lata is identified. Deep to that, the fascia iliaca, which envelopes the femoral nerve. Medial to the femoral nerve, the femoral artery, and more medial, the femoral vein. The iliac-os muscle lies deep to all structures. This is a demonstration of the needle insertion point for in-plane needling, with the needle coming in from the lateral aspect of the probe, aiming to keep it in line with the ultrasound beam. For out-of-plane needling, this is an example of the needle insertion point in relation to the probe. This is a video of an actual block. The needle is being inserted from the left-hand side of the screen, laterally. You can see the needle tip here passing below the femoral nerve, and a hydrodissection technique being utilised to dissect the femoral nerve off the fascial surface of the iliac-os. As the needle passes deep to it, you can see it becoming surrounded by local anaesthetic. The needle is now walking above the femoral nerve and injecting local anaesthetic above it. The whole time the needle tip should be visualised, and you can see the separate fibres of the femoral nerve being surrounded by local anaesthetic.
With a bit of luck, the patient is now settled and can get to the operating theatre. The reality is this can take well over 24 hours, especially in complex older patients. As a result, they'll need IV fluids, an ECG, baseline bloods and a chest X-ray. In many hospitals, the patient's admitted under a general physician or geriatrician as well as the orthopaedic surgeon in order to look at the cause of the fall and assist with planning for OT. And let's face it, just about everyone seems to be on aspirin, clopidogrel or a NOAC. I think that'll just about do for fractured neck of femur in one coffee with a bonus ultrasound guided femoral nerve block. Stay upright. I'll see you next time. Cheers.